Okay, so we're going to plow forward. Okay, I just forgot to say one thing about the gamma motor neurons that I wanted to mention. In terms of mechanism of upper motor neuron findings and spasticity, there's a lot to it. It's a lot more complex than this. But one of the things that's going on is, that the upper motor neurons are regulating everything that's happening in your spinal cord, including the gamma motor neurons. And so if you have an upper motor neuron lesion, you actually lose some of the inhibition on the gamma motor neurons. So now they're always overactive. And so the muscle spindle is much tighter than it should be. Okay, and that's why you get this velocity-dependent spastic weakness. It has to do with the gamma motor neurons. Okay, so now we're up to the medulla. Okay, so most important things here first are nucleus ambiguus. Remember, motor nucleus, motor for 9 and 10. And so what are things that affect the nucleus ambiguus? The two most important conditions, one would be ALS, okay, because these are lower motor neurons that feed motor axons into cranial nerves 9 and 10 for talking and swallowing. So nucleus ambiguus degenerates early in ALS, and that would give you the bulbar palsy. Okay, the other really important condition is lateral medullary syndrome. Okay, nucleus ambiguus is in the lateral medulla. Remember, that's supplied by the pica, and the pica comes off of the vertebral artery. Okay, so with the destruction of nucleus ambiguus, you get dysphagia, dysarthria, hiccups, and that's with lateral medullary syndrome. Okay, so here's the lateral medulla. Okay, and the nucleus ambiguus, as we said last year, is ambiguous. You can't see it. It's somewhere here in the mass of all these other neurons. Okay, but you want to, that would be an anatomical structure worth remembering. Okay, so lateral medullary syndrome, which we've probably gone over many times here, but along with Brown-Séquard would make a top 5 list here of high yield information. And people love to ask these questions just because there's so much anatomy here, so you have to know a lot to put this together. So the most obvious cross-finding in lateral medullary syndrome is one side of the face has loss of pain and temperature, the opposite arm and leg has loss of pain and temperature. And remember, that's what we look for in any brainstem syndrome, ipsilateral cranial nerve, contralateral, motor, or sensory. So one side of the face is numb because you involve the spinal trigeminal nucleus and tract. Okay, so the trigeminal involvement gives you the face, and we just talked about this pathway, the spinothalamic tract, which goes to the lateral medulla. So that's why the opposite arm and leg has a loss of pain and temperature. Okay, here's the nucleus ambiguous. Okay, so a stroke there gives the patient dysarthria, dysphagia, hiccups. The vestibular nuclei are in the lateral medulla, so now we have information from the inner ear. There's a mismatch, and so patients have vertigo. They have nystagmus. Okay, the sympathetics travel through the lateral medulla, so that's why lateral medullary syndrome gives you an ipsilateral Horner's syndrome. Okay, and then we have the inferior cerebellar peduncle, which connects the medulla to the cerebellum. So the pica supplies the inferior cerebellar peduncle and the undersurface of the cerebellum, so patients have ipsilateral ataxia. All right, so it's a lot of different things. This is one stroke syndrome that is often not, in your diabetic hypertensive patient. I think I mentioned my nephew who had this looking up painting, and he dissected his vertebral artery. So trauma, chiropractic adjustment, things like that can affect the vertebral artery, and a dissection will give you this syndrome. Okay, so know that one very well. The nucleus solitarius is also in the medulla, and so this nucleus is important for taste. Okay, remember the anterior 2/3 of the tongue for taste is 7, back of the tongue is 9. Okay, and both of these feed into the nucleus solitarius. And the nucleus solitarius also, all of the receptors for blood pressure, feed into the nucleus solitarius. So it's sensory. Nucleus ambiguus is motor. So a lesion here could give you a loss of taste and some autonomic instability, some blood pressure instability. All right, so we have stretch receptors, for example, here in the carotid body, and so these, not the greatest picture here, but goes into the nucleus solitarius, and so when your blood pressure is going up, your pulse is elevating, then the nucleus solitarius actually inhibits the sympathetics. Okay, that'll bring your blood pressure down, and it also activates the dorsal motor nucleus, which is in this same area. Dorsal motor nucleus of the vagus, remember, is parasympathetic. Parasympathetic is going to slow your heart rate, bring your blood pressure down. Okay, so this is the reflex involved here with solitary nucleus and dorsal motor nucleus of the vagus. So again, dorsal motor nucleus of the vagus does a whole lot of things here, but I think for neuro, we're going to mainly emphasize here the effect on the heart and the blood pressure that happens in this reflex. All right, medial medullary syndrome. So the structures here in the medial medulla are the medullary pyramids. So remember, the pathway in the medullary pyramids is the corticospinal tract, the medial lemniscus, and the hypoglossal nucleus. Okay, so the blood vessel here is the anterior spinal artery, but notice how different this is from anterior spinal artery stroke in the spinal cord. Totally different. Okay, because anterior spinal artery stroke now extends all the way back here to the hypoglossal nucleus. Okay, so remember, what are we looking for in a brainstem syndrome? Ipsilateral cranial nerve. Well, in this case, it's hypoglossal. Contralateral motor and sensory. So if we evolve the medial lemniscus, the opposite side of the body is going to have loss of vibration and proprioception, okay, not pain and temperature. And if you have a lesion here, the corticospinal tract hasn't crossed yet. So we get a contralateral hemiplegia. Okay, so we get tongue deviation, and then the opposite side of the body is weak and has loss of vibration and proprioception. Also, just worthwhile pointing out here that look how far the medullary pyramids are away from the lateral medulla. So lateral medullary syndrome, you will never have upper motor neuron findings or weakness, okay, because that pathway is medial. Okay, a few other things. Sorry, poor quality picture here, but just this area back here, kind of medulla, fourth ventricle area. This is the area postrema. Remember, that's the vomiting center, so it lacks a blood-brain barrier. So if you were asked about, a chemotherapeutic medication, why does the patient throw up, you'd want to be able to kind of have an idea of where the area postrema is. Okay, Cerebellopontine angle tumors. Remember that cranial nerves 7 and 8 exit here in this cerebellopontine angle. So the story is usually hearing loss initially, maybe ringing in the ears, and then facial weakness. So this is going to be lower motor neuron, right? So it's the forehead and the lower face. And the trigeminal nerve is in this area also. So oftentimes you'll get some facial numbness. And of course here we can see some compression of the cerebellum. So remember, cerebellar lesions give you ipsilateral ataxia. So the ataxia would be on the same side here as the mass. So this is usually an acoustic schwannoma. Okay, so here we see the cerebellopontine angle right here. So there are cranial nerves 7 and 8. And again, not too far away is the trigeminal nerve. And of course, the cerebellum is right there. Okay, so I tried to label what I thought would be the highest yield. These are in your handout from the difficult brainstem section here, but certainly you need to know the medial medulla, right? So there's the medullary pyramid, medial lemniscus, hypoglossal nucleus. Okay, right next to the hypoglossal nucleus is the dorsal motor nucleus of the vagus, and the solitary tracted nucleus is right next to the dorsal motor nucleus of the vagus, which makes sense because remember that information about blood pressure and pulse is coming into the solitary nucleus and tract, and so it communicates with the dorsal motor nucleus of the vagus to appropriately bring your blood pressure down. And then here's the vagus nerve. Okay, so we can just kind of follow that from the dorsal motor nucleus of the vagus and out. Okay, remember there's only one nerve that exits between the pyramid and the inferior olive. Okay, last January we talked about this. So this is the hypoglossal nerve, and so here's the nucleus, and you can kind of see the fibers coming down and exiting right here. Okay, the dog ears of the medulla here, these are the inferior cerebellar peduncles connecting the medulla with the cerebellum. Okay, the pons, of course, the trigeminal nerve, we can see externally next to the pons, and so this will be maybe more of an anatomy question, but the three branches of the trigeminal nerve, ophthalmic, of course, goes through the superior orbital fissure, maxillary through the foramen rotundum, and mandibular branch, which includes also your motor fibers, would go through the foramen ovale. Okay, so remember the motor fibers here with the mandibular branch, so the chewing muscles, important the lateral pterygoids, which are important for jaw opening. Here that's trigeminal nerve. Okay, so just like with the hypoglossal nerve, remember if you have a hypoglossal nerve lesion, that half of the tongue is going to atrophy, so the tongue will point towards the side of the lesion. And you get the same thing with a trigeminal nerve lesion, that the chin will deviate now towards the side of the lesion if you ask the patient to open their mouth. All right, so here are the three branches. Remember the ophthalmic division of the trigeminal nerve supplies the cornea. So the maxillary, cheek area, mandibular. Trigeminal neuralgia is almost always here in the maxillary V2 distribution. All right, and I know this is difficult now because you haven't probably thought about this in a while, but the trigeminal system is involved in some important reflexes. So the mesencephalic nucleus, okay, you need to know where your jaw is in space when you chew your food, right? So this is a function of the mesencephalic nucleus. So it's for proprioception. Okay, when you tap on the jaw and it snaps back up, that is stimulating the mesencephalic nucleus. Okay, the corneal reflex, though, is mediated by the principal, or sometimes called the chief trigeminal nucleus. Okay, so touching the cornea and the eyes close, that's the principal or chief trigeminal nucleus. Okay, and then trigeminal sensation for pain and temperature, though, and this is the one involved in lateral medullary syndrome, is called the spinal or descending trigeminal nucleus and tract. Okay, so these are just like, you know, proprioception, pain and temperature we have in the arms and legs, but when you get up to the face, it's a little more specialized. All right, so let's show you this. Here we have muscle spindles, you know, for chewing muscles, just like we have in the extremities. And so this goes up to the mesencephalic nucleus here. Okay, and so of course that needs to talk with the muscles that are involved in chewing. So there's a connection here between the mesencephalic nucleus then and the motor nucleus of the trigeminal nerve. Okay, so again, mesencephalic is proprioception, and also when you tap on the jaw and the jaw snaps up, that's going to go up to the mesencephalic and then right back to the motor nucleus of trigeminal so that your jaw moves. Okay, the corneal reflex, which again is mediated by the principal or the chief trigeminal nucleus. You touch one cornea, both eyes close, and so the pathway here, again, it's the ophthalmic division that supplies the cornea. So this goes back to the chief or principal trigeminal nucleus, and then to the facial nucleus, and out to orbicularis oculi to close the eye. So facial nerve closes the eye. Okay, but what actually happens is from the chief trigeminal nucleus, it actually supplies both facial nerve nuclei. So that's why touching one cornea should cause both eyes to close. Okay, so if we have a lesion here, a severe lesion of the trigeminal nerve, then you touch one cornea and nothing's going to happen. Okay, whereas if we have a lesion out here, let's say the patient has Bell's palsy, here's the facial nerve. Okay, now you can touch the cornea in that eye, and the ipsilateral eye won't close, okay, but yet the opposite eye closes. And we call that the consensual reflex here, so the other eye will close. Okay, so remember that for the tongue, we have taste, but there's also just the ability to sense touch for the tongue, and that is a function of the trigeminal nerve. So again, taste is 7 and 9. So if we have facial weakness, if it's lower motor neuron, it's going to be one whole side of the face. So this is normal here. We have wrinkling of the frontalis muscle. Patient can smile here. And so acutely in a Bell's palsy, since the facial nerve closes the eye actually can't close and it's open wider. That's not really that evident here. Okay, so this is the big problem in Bell's palsy is these patients can get corneal damage, so they need to tape their eyes shut for a while, especially when they sleep at nighttime. So you need to be able to distinguish upper versus lower motor neuron facial weakness. Okay, so in a Bell's palsy or any facial nucleus lesion, it's going to be forehead and lower face that'll be affected. Okay, but if we put a lesion up here, so remember, what is the cortical bulbar tract? It's the pathway that connects the cortex to the brainstem. So all of your cranial nerves are activated by the cortical bulbar tract, but what's unique here about the cortical bulbar tract is we get a bilateral supply to the portion of the facial nucleus that supplies your forehead, but only a contralateral supply to the lower face division. Okay, so that's why if we have a stroke here involving the cortical bulbar tract, then the patient will just have lower facial weakness. Okay, so a patient in the ER who has just lower facial weakness, we're more concerned about that patient, okay, because that would be more suggestive of a stroke. Bell's palsy is going to look more dramatic. It's the whole side of the face, but that has a great prognosis. Okay, so the seventh nerve supplies the stapedius, and that's important for dampening sound. So that's why when patients have Bell's palsy, they're going to complain that sounds are louder in that ear. Okay, very irritating. Okay, the only Pontine syndrome here we've talked about with crossed findings, and there are a whole bunch of variations on this, but 6 and 7 are right next to each other in the Pons. So if you have a stroke there, you're going to get an ipsilateral 6 and a 7th nerve palsy. So 6th nerve supplies the lateral rectus. So when the patient then tries, if I have a right pontine lesion and I try to look to the right, left eye moves over, but the right eye can't abduct. And if you destroy the facial nucleus, then you're going to get a lower motor neuron facial weakness. Okay, but here's the corticospinal tract. Okay, so this is our crossed finding with a stroke in the Pons in this area. Okay, so we're going to get a contralateral hemiplegia. Okay, you would have been happy last year if I told you only need to know 4 things on this slide. But here's the Pons. So worthwhile knowing that the basilar artery, it lies on the Pons. Remember the 6th nerve comes out midline, right between the Pons and the medulla. And here we have the cranial nerves 7 and 8 in the cerebellopontine angle. Okay, so for this exam in a couple of weeks, I'm not going to try to pull out some little nucleus here and ask you, is it the medial or lateral cochlear nucleus or something? So we're not looking for that kind of detail. Okay, so here's another picture of the Pons. Now this is worth knowing though, that here's the 7th nerve nucleus and here's 6. And so it's important just because it's clinically relevant that the 7th nerve for some strange reason doesn't just exit right out. It has to take a jog around the 6th nerve nucleus like that. So here's the 7th nerve fiber, there's the 7th nerve fiber. So that's why a lesion here will give you a 6th and a 7th nerve palsy. When we look at the external surface of the brainstem, cranial nerve 6 and 7 are miles apart. Okay, so we only get a 6th and 7th nerve palsy together with a lesion here. Okay, the other thing I'll mention, and just because it is clinically relevant, so here's the medial lemniscus. It lies down, it starts to move out laterally, but the central tegmental tract connects the inferior olivary nucleus with the red nucleus. Okay, and a lesion here, anyone remember? Well, maybe you're looking at your handout. What does that give you? Palatal myoclonus. Okay, just it's such a well-recognized, if you see a patient, their palate is just continually going up and down, up and down, up and down. Where's the lesion? It's in the pons. And if you had to say what pathway is involved, it's the central tegmental tract. Okay, the midbrain has things that just seem to look more comfortable here. So we've got the cerebral peduncle. So remember our corticospinal tract and cortical bulbar tract here are traveling in the cerebral peduncle. Here's the third nerve, okay, and the Edinger-Westphal nucleus. Okay, and the oculomotor nucleus, they're both right here. Here's the substantia nigra and the red nucleus. Okay, here's the cerebral aqueduct and the periaqueductal gray. Okay, so remember this is periaqueductal gray, whoops. Lots of opioid receptors there, important for pain. And then we have the superior colliculus back here. So as a very big picture, you should know that this part of the midbrain is very important for vertical eye movements. Okay, and someone just asked me during the break, did we ever learn the anatomy of vertical eye movements? And my answer was, it's so much fun, the vertical eye movements. There's so much interesting anatomy, but it's just, it just takes too long to go into, and it's very kind of hardcore neuroanatomy. But I do want you to know that vertical eye movements are a function of this area of the midbrain. Okay, why? Because here's the pineal gland. Okay, so if you have a pineal tumor and that compresses on this area, then remember we get a problem with vertical eye movements called Paraneoplastic syndrome, which we'll come to in just a minute. All right, so third nerve palsy, the eye is down and out. We have ptosis. Okay, so the third nerve, remember, comes out between the posterior cerebral artery and the superior cerebellar artery. But the more important artery to associate with the third nerve is the PCOM right here. And why is it more important? Because aneurysms form on the anterior circulation. Okay, so we just don't see aneurysms here very often, but an aneurysm here all the time. So a PCOM aneurysm ruptures, the patient has a headache and gets a third nerve palsy. If we have a tumor or bleed in the brain and the uncus herniates, that will give the patient a third nerve palsy. Okay, so here's a list. I think if you know these 5 causes of a third nerve palsy, you should be in good shape. Okay, so uncal herniation, what's your key thing there? The patient's in a coma. Okay, you're not going to see a patient in clinic talking to you who has uncal herniation. PCOM aneurysm, the key story there is the patient had a severe headache and they come in the emergency room with severe headache and they have a third nerve palsy. Okay, from our last lecture, ischemia of the third nerve, these are usually patients with diabetes. They have a third nerve palsy, but it spares the pupil. Okay, pupil sparing third nerve palsy is ischemia. Weber's syndrome is the stroke in the midbrain that affects the third nerve, but also the cerebral peduncle. So the key part of the vignette here is they have a contralateral hemiplegia. Okay, and then finally, anything in the cavernous sinus, like cavernous sinus thrombosis, gives us a really ugly third nerve palsy because there's pressure behind the eye. You have also cranial nerves 4 and 6 are in the cavernous sinus, so it's not just third nerve. They also can't abduct the eye. They don't have the internal rotation of the eye that the fourth nerve, function of the fourth nerve. And they also have numbness in the V1, sometimes V2 distribution. And usually the eye is getting pushed forward. That's proptosis. The eye is red. So this has a much different kind of presentation. So here's Weber's syndrome, midbrain stroke. So ipsilateral third nerve palsy, contralateral hemiplegia. And here's a patient with a cavernous sinus thrombosis. And I wouldn't expect you to know what you're looking at here, but this is all congestion in the cavernous sinus. All right, so the patient has not just a third nerve palsy, but the eye is red, there's swelling, and if we were to lift up the eyelid, you'd actually see the eye kind of pushing out of the globe there. All right, the sympathetics. So we talked about the descending sympathetics that goes through the lateral medulla, right? So it's part of lateral medullary syndrome. First synapse is C8T1. So from hypothalamus through the pons, lateral medulla, C8T1. Second order connection loops over the lung around the subclavian artery to the superior cervical ganglion. Okay, and from there the fibers branch off. If we're talking about blood vessels and sweat glands, it's with the external carotid artery. Okay, and to the pupil and to Mueller's muscle, which has its minor effect to elevate the eyelid. This goes along with the internal carotid artery. Okay, don't try to learn here about this connection. That's a little too complicated. But internal carotid artery is to the pupil and Mueller's muscle. Okay, so a lesion of sympathetics then, because sympathetics are dilating the pupil, then we get a small pupil, that's meiosis. And because we lose the innervation to Mueller's muscle, we get a little bit of ptosis. Okay, and if the lesion is either a first or a second order, then we may get anhidrosis with some loss of sweating. Okay, so here's a patient with a Horner syndrome, and remember that what's really helpful to do is just dim the lights. Okay, so in the normal pupil here, you dim the lights, pupils get large. So if you weren't sure if there was pupillary asymmetry now, when you dim the lights, now you're convinced that this is real. Okay, so causes of Horner syndrome, one is a pontine hemorrhage. Now your patient's in a coma, right? But when you lift the eyelids up, they have pinpoint pupils. So you knock out all of the descending sympathetics. Lateral medullary syndrome. Okay, you could have a lesion here of the spinal cord or C8T1 nerve roots, but that would be pretty rare. And of course the classic, maybe this would be also make our top 5 list here, would be an apical lung tumor, right? A smoker that would have a Horner syndrome. Okay, along here, probably the other thing worthwhile knowing is if you have trauma to the neck and you have a dissection of the internal carotid artery, the swelling of the artery there would compress the sympathetics and you could get a Horner syndrome. Okay, those would probably be the ones I would remember. Okay, now here was the trick question here about pupillary asymmetry and the optic nerve. So first let's just do the normal anatomy here. So light here in one eye, going back to the Edinger-Westphal nucleus, has a double crossing. Okay, so optic chiasm, and also there's another crossing back here to the Edinger-Westphal nucleus. Okay, so the key thing here is light in one eye will equally stimulate both Edinger-Westphal nuclei. Remember, that's the parasympathetic contribution to 3. And so out via the ciliary ganglion, both pupils constrict. Okay, so that's the normal. Okay, so if we have a patient like that has multiple sclerosis with optic neuritis, so not much of the light is going to get in. Okay, so when you shine the light in this eye, the pupils may not constrict as briskly, but that's often hard to appreciate. You shine the light over here, at least theoretically you would think that there should be a dramatic difference, but that's often hard to appreciate. So what we really need to do, well, here we can see shining the light here in the left eye, pupils don't constrict that much. Shining the light here in the normal eye, we get a good pupillary constriction. But what really makes this dramatic is when we swing the flashlight back and forth. Okay, because now the light is in this eye, both pupils are getting blasted with 100% light, and now we swing the light back to this eye, and now both Edinger-Westphal nuclei are getting very little light stimulation, and so both pupils dilate. Okay, but at no point is there asymmetry of the pupil size. Okay, so this is frequently in some way kind of a trick question you're asked. But if we have an optic nerve lesion, the pupils will always be symmetrical. Okay, but it's that dilation of the pupil when you swing the light back to the bad eye, and that's the afferent pupillary defect. Okay, that's the objective finding in an optic nerve lesion. Okay, and the anatomy of this, the Argyll Robertson pupil, is not as well understood. This is looking at it here in a different, from a different orientation. But here's light going again back to the pretectal area to both Edinger-Westphal nuclei. I wish this were shown on the other side, but it just shows half of it here, so constricting the pupil. But your pupils also constrict when you're having a patient follow your finger and then you have them follow it to their nose. Okay, And that pupillary constriction is via a totally different pathway. It's not that well understood, but you're using vision, right? It's the occipital lobe that's tracking. So it also innervates the pretectal nucleus, but via a different route. And so that's why we can get a dissociation between pupils, whether they constrict to light versus accommodation. Okay, so when we get dissociation there, it is usually with lesions right back here, okay, like neurosyphilis. We might see that, like in an HIV patient, where their pupils don't constrict to light, okay, but they do constrict to accommodation. Okay, the other condition that might do that is, remember, the pineal gland sits right here. So if we have a pineal tumor, we can also get a dissociation between light and accommodation constriction. Okay, just one nerve to know here from this section. So there is the trochlear nerve. Important because it's the only nerve that exits the dorsum of the brainstem, right? Every other nerve goes out, forward. Okay, and of course remember the trochlear nerve, that its main function is down and in. Okay, and so when your eye is looking towards the nose, it pulls it straight down towards the nose. The further out your eye gets laterally, it has more of a function to intort. There's a rotational aspect. Okay, so here we have a pineal tumor, and this is the Paraneoplastic syndrome. So remember I said that this part of the midbrain is very important for vertical eye movement, so these patients have a hard time looking up and down. They also have, especially when they try to look up, their eyelids retract. So you can see this patient kind of looks surprised. But that's the reflex when these patients try to look up. That's called Collier's sign. And when they try to look up, instead of their eyes going up, they often do this. And that's called a convergence retraction nystagmus. Okay, so that inability to look up, the eyelid sign, the convergence retraction nystagmus, your lesion is right here. Okay, so that could be several things, but a pineal tumor would be the most common cause. All right, the cerebellum. Okay, so just, yeah, I know, I'm tired of talking about this too, so. All right, so, no, it's still exciting, that's okay. The Mossy fibers and climbing fibers. I don't know why this is often a big deal, but almost seems arbitrary in some ways, but Mossy fibers are all of the input into the cerebellum. It's called Mossy fibers. Climbing fibers, please associate that with the inferior olivary nucleus. So we give those fibers a different name, and they do have a different function, I guess, when they enter the cerebellum. Okay, so we talked about these 4 spinocerebellar pathways, giving information to your cerebellum about where the limbs are in space. Okay, I think the 2 you should know are for the legs, the dorsal and the ventral spinocerebellar tract. Okay, and so there's slightly different information. So for muscle spindles, it's the dorsal spinocerebellar tract. Ventral is mainly from Golgi tendon organs. Okay, 1A fibers are a little faster than 1B fibers, but I don't think that's that important. Clark's nucleus, I put this in yellow because it's just such a distinctive nucleus that you can see on a spinal cord section, and it is information, a relay nucleus that will become the dorsal spinocerebellar tract. Okay, now all of the information going from the spinal cord up to the cerebellum goes through the inferior cerebellar peduncle, with the exception of the ventral spinocerebellar tract. So maybe another thing to point out here is this pathway is really unusual. Okay, from your leg to the cerebellum, all of the other pathways don't cross. They just go up to the same side of the cerebellum. The ventral spinocerebellar tract crosses twice. Crosses once in the spinal cord, and then it crosses a second time via the superior cerebellar peduncle. The net result is the same. It's ended up as the same place, but it just takes a long way distance to get there. So we call this unconscious proprioception. So when a patient is aware, yes, my toe is now moved up or down, That's posterior column function. That's conscious proprioception. Okay, unconscious proprioception describes your cerebellum always monitoring where your limbs are in space so that it can provide that feedback to the motor cortex of the brain so that your movements are always coordinated. Okay, so these pathways then involved in unconscious proprioception. Now we have these deep cerebellar nuclei. The largest one is the dentate, okay, and emboliform, globose, vestigial. Remember, dogs eat good food. So the dentate is the largest, and basically the further anything is lateral in the cerebellum, the more lateral the ataxia is. So if you've got a cerebellar hemisphere lesion, you're going to have a lot of finger-to-nose ataxia. Or if you have a lesion in the dentate, you're going to get a lot of finger-to-nose ataxia. The closer to the midline the lesion is, the more you're going to have midline ataxia. So truncal, wide-based ataxic gait. So like a lesion here of the vestigial nucleus or the vermis of the cerebellum, like an alcoholic patient would get degeneration here and would have a truncal ataxia. Okay, so the vestigial nucleus, remember that's midline, and so it supplies upper motor neuron pathways that are midline. The dentate nucleus is more lateral here, and it's involved in communication with the motor cortex for more distal fine coordination. Okay, so again, vermis, flocculonodular lobe, vestigial nucleus, these are all midline structures. Okay, so any lesion here, it's a wide-based truncal ataxia. As we move out more lateral to the paravermis, that would be more proximal muscles that might be involved. Okay, globose and emboliform. The lateral hemispheres lesion there will give you the more significant, what you think of as, the severe finger-to-nose ataxia. Okay, and again, the dentate nucleus relays information from the lateral hemispheres. So the cerebellum is communicating with the motor cortex, like the corticospinal tract, to continually regulate movement. Okay, so remember, you've got a vermis, a flocculonodular lobe, so this is very important for also communicating with your eyes. Okay, so eye movements here would be an important function of the flocculonodular lobe. Okay, and here we have the lateral hemisphere. If you look at a sagittal section, we have a primary fissure here of the cerebellum. Remember, we call this folia, which are kind of the equivalent of the gyri here in the hemispheres. Okay, don't worry, don't panic on this picture. I just will make one little point here, okay, which is that the climbing fibers, remember, where do these come from? Inferior olivary nucleus, okay, that these ascend up and are talking with Purkinje cells. Okay, everything else that comes into the cerebellum are Mossy fibers. Okay, please don't spend a lot of time with this. But I would maybe also just mention that the Purkinje cells here, 100% of the output from the cerebellum is via the Purkinje cells. Okay, so we never went over all the circuitry of this, and I just don't find a lot of value in learning this clinically. But all of the output is via the Purkinje cells. So when we talk about like paraneoplastic syndromes, where we have antibodies going against the Purkinje cells, well, that causes profound ataxia because all of the cerebellar output then is affected. Okay, so let's now just back up and get the big picture like we did way back in January. So here's the corticospinal tract moving the opposite arm and leg. Okay, and so remember that the cerebellum needs to be informed about that movement. And so the pathway involved here is the cortical pontocerebellar tract. And this is just relaying the motor program, what you intend to do with your arm or leg, to the cerebellum. And that gets in through the middle cerebellar peduncle. Okay, so there's only one pathway in the middle cerebellar peduncle, and that is the cortical pontocerebellar tract. Okay, every bit of movement you do is going through this pathway continuously to the cerebellum. Okay, so now you're moving your arm or leg here because of this, motor program. And so your cerebellum needs to know how accurate you are at performing that movement. So here we have all of the Spinocerebellar tracts, 2 for the legs, 2 for the arms. Remember, 3 out of the 4 go through the inferior cerebellar peduncle. And you've got this oddball ventral spinocerebellar tract that crosses in the spinal cord, and then it goes through the superior cerebellar peduncle. Okay, but this is your unconscious proprioception now, feeding into the cerebellum. Okay, anything going in or out of the cerebellum has to relay through these deep cerebellar nuclei. Okay, so now the cerebellum knows the intended movement, and it knows the actual movement. It compares the two, and in real time sends that information out via the dentate nucleus and the superior cerebellar peduncle back up to the motor cortex, and so your brain can make a corrective movement. Okay, so why do cerebellar lesions give you ipsilateral ataxia? Well, let's just say this is the left and this is right. So if we destroy the right cerebellum, notice it can no longer communicate with the left hemisphere of your brain to move the right side of your body. So the ataxia then is always on the ipsilateral same side. Okay, so you should associate the inferior cerebellar peduncle with mainly these spinocerebellar tracts coming in. You should associate the middle cerebellar peduncle with the corticopontocerebellar tract, telling you the intended movement. And you should mainly associate the superior cerebellar peduncle with output to the motor cortex. But remember that one exception here, the ventral spinocerebellar tract going in to the superior, through the superior peduncle, cerebellar peduncle. Okay, you survived that? Okay. So let's go through some clinically. Here we have a cerebellar hemorrhage. And remember, of our hypertensive hemorrhages, these are the ones that are fixable, or we can do something for. So this patient is going to have ipsilateral ataxia. Okay, and again, I'm mentioning this for boards than practically, but at least theoretically, with cerebellar lesions, you can have hypotonia and pendular reflexes. I keep checking for this, and I can just never find it. But you can lose tone, supposedly, so that, for example, if someone has a left cerebellar lesion and you check the patellar reflex, because of the loss of tone, the leg may just keep swinging back and forth. Okay. Any cerebellar lesion will often affect pathways involved in eye movements. Remember, the flocculonodular lobe is very important for eye movements, so we'll get nystagmus. Okay, the common childhood tumor, a medulloblastoma. These tend to be midline. All right, and so what often happens then, because they're midline, is you affect the flow of CSF. So CSF through the cerebral aqueduct down to the 4th ventricle. So we get a non-communicating hydrocephalus, so the lateral ventricles dilate. So this is really an emergency, and we get increased pressure in the brain, headaches, maybe papilledema in these children. And because the tumor is midline, they're going to have more of a wide-base truncal gait ataxia. Okay, so alcoholism affects the cerebellum in a couple of different ways. Chronic alcohol use, we can see here we just get severe atrophy of the cerebellum. And so this tends to be more midline, so your usual alcoholic patient is not so much finger-to-nose ataxia, it's more of a wide-based gait ataxia. And then, of course, we have Wernicke's encephalopathy. Remember, one of the parts of the triad is severe gait instability. Okay, so they have a gait ataxia, ophthalmoplegia, usually looks like a bilateral 6-nerve lesion, and they're confused. Okay, so what usually triggers Wernicke's encephalopathy? Glucose, right? So this is frequently iatrogenic. The patient didn't come in with it, but then in the hospital, they get the triad of the Wernicke's encephalopathy. Okay, and so of course that's thiamine deficiency, and you look for lesions in the mammillary bodies there. Okay, another condition where ataxia is the main feature is Friedreich's ataxia. All right, so this is another trinucleotide repeat. So we've got myotonic dystrophy, now Friedreich's ataxia. This is GAA on chromosome 9. And so these are young individuals that have significant degeneration of cerebellar pathways, the spinocerebellar tracts, but also the peripheral nerves and the posterior column. So you not only lose the unconscious proprioception, but the conscious proprioception. The patients don't know where their legs are in space. So gait instability and falling is quite profound in these patients. And they can even have some corticospinal tract degeneration. So they have some upper motor neuron findings. So they have a lot of things going on. So here in a case of Friedreich's, notice the dorsal and ventral spinocerebellar tract are affected, corticospinal tract, posterior columns. Okay, so this could look a little bit like B12 deficiency, but of course in a child presenting with such severe ataxia, that would be different than a usual B12 presentation. Okay, if we deprive the cerebellum of information, that would be an example in Friedreich's, but also even if we're losing information up through the posterior columns, we call this, quotes, a sensory ataxia. Patient doesn't know where their limbs are in space, so they're falling. It's not really a cerebellar lesion at all, but things that profoundly affect the posterior columns, so we mentioned B12, tabes dorsalis, posterior spinal artery stroke, Friedreich's, of course, would be another. Okay, phenytoin toxicity. Remember, phenytoin's unique because the enzyme gets saturated past a certain point, so the blood levels can skyrocket. And when that happens, patients feel drunk, and it affects the cerebellum and vestibular pathways. So they complain of, vertigo, and they have nystagmus, and they'll have ataxia. All right, one of the paraneoplastic syndromes, which can occur with several different cancers, ovarian, breast, and small cell, you get antibodies against the Purkinje cells. And so if you have a patient, just an adult, presenting with progressive ataxia, and your brain scan looks pretty normal, well, do a Purkinje cell antibody test. Okay, and then that will lead you to search for the source. What is the cancer that is causing this? Okay, past the cerebellum. Now let's talk about cranial nerves. Very briefly, the olfactory nerve. I don't know that I've ever seen this, but I've seen it asked that meningiomas often like to grow at the base of the skull, okay, right where the olfactory nerve fibers are. And so if you have a patient with loss of smell and headaches, then you'd want to think about an olfactory groove meningioma. Remember, most patients with Parkinson's disease lose their sense of smell. Okay, head trauma, where you shear the olfactory nerve fibers as they're going through the cribriform plate. That's very common after a severe head trauma. Most causes of loss of smell are not neurologic. Patient smokes or they have something else going on. Remember, when you give smelling salts, like to activate, someone, and we don't do this very often clinically, but that's not a test of olfaction. Okay, that's trigeminal pain fibers that you're activating when you do that. Okay, and then just remember the olfactory nerve goes right back to the uncus. Okay, so the uncus is the most epileptic part of the brain. So if we have a seizure activity beginning in the medial temporal lobe, uncus, then it's not pleasant. It's burnt rubber, it's something foul. I've never heard a patient describe a pleasant smell with a seizure beginning there. Okay, so here are different patterns of visual loss. So we just did this lecture recently, but of course if we have a lesion anterior to the chiasm, it's monocular visual loss. If we have a lesion at the chiasm, typically it's a bitemporal visual field loss. If we have a lesion of the optic tract, because of the rotation of the fibers there, we get usually a contralateral incongruous, not identical side to side, homonymous hemianopia. Okay, and then remember the blood supply back here to the optic tract and lateral geniculate. Only one I want you to know is the anterior choroidal artery. Okay, and this is the one where you get that area of preserved, that beak-like zone of preserved vision. So if you get a visual field deficit like that, that's an anterior choroidal artery stroke. Oops. Okay, if we affect the optic radiations as they loop down to the temporal lobe, that's Meyer's loop, you get not the whole quadrant, you get a slightly less than that. This pie in the sky, superior quadrantenopsia. If you destroy the parietal lobe now, you get more than a quadrant, right? You get everything else. Okay, and usually as we get back to the occipital lobe, if you just had a pure, perfectly symmetrical quadrant that's knocked out like this, that's going to be more likely a lesion in the occipital lobe. And remember, everything is reversed with vision. So if you have a lesion in the superior portion of the occipital lobe, the visual deficit is going to be in the inferior, opposite inferior quadrants. Okay, and I wish this drawing didn't show the preserved macular vision, but you know, if you have a PCA stroke way back there, then you would have some macular sparing. Other causes you wouldn't. If you affect the inferior portion of the cerebellum, what have I been saying? Cerebellum, sorry, occipital lobe, then you'll get the superior quadrant knocked out. Okay, and if you see this, it has to be PCA stroke. Okay, macular sparing, everything affected except the macular vision, and this is because of the dual blood supply of the macular fibers. So the MCA supplies the macular fibers also, so you get a preserved central vision. Okay, recognize the lateral geniculate. Remember the Napoleon's hat? So therefore the fibers coming in, that's the optic tract, and then here are the optic radiations going back to the occipital lobe. Okay, so optic neuritis we've talked about. Remember, it's central vision loss, severe loss of visual acuity, pain behind the eye, worse with eye movements, and you can see enhancement of the optic nerve if you do an MRI scan. Okay, from our recent lecture here, again, if you're oriented to the chiasm, it's monocular visual loss. So central retinal artery here coming off the ophthalmic artery. Okay, so this is a retinal problem here. So we have visual loss, and this is the one where we get the cherry red spot. Okay, if we have papilledema, remember there's nowhere for that pressure to go. So here is the subarachnoid space, and so that pressure is going to go forward to the optic nerve head here. And so remember our patients with like pseudotumor, idiopathic intracranial hypertension that have headaches, usually young women, overweight, this pressure here often will cause brief episodes of visual loss. So they bend over or something, and they'll briefly go blind, sit up again, and things come back to normal. But a more permanent thing that we could see with papilledema is just a constriction of the visual fields, so tunnel vision. Okay, and the blind spot here, and I should show you normal by contrast, but the blind spot gets enlarged in patients that have papilledema as well. Okay, some other vascular syndromes. Ischemic optic neuropathy, we want to divide into either arteritic or non-arteritic. Arteritic is giant cell arteritis. Okay, non-arteritic is just your patient that has diabetes, hypertension, and that has a stroke of the optic nerve. So the non-arteritic is, what happens here is the posterior ciliary artery via very complex autoregulation here of supply to the optic nerve head is affected usually when patients sleep at nighttime. All right, so they have maybe sleep apnea, they're not oxygenating well, their blood pressure goes down, and then they wake up with a stroke right here, and they lose vision in that eye. Okay, there's a watershed area here, so usually it's the inferior quadrants that are affected in the ischemic optic neuropathy. Okay, if it's arteritic, could look just like this, but now remember we've got a patient with jaw claudication, and we have a patient that has headaches, older individual. That would suggest we have an arteritic form. Okay, as we move back here to the posterior white matter, so two things we've talked about in this course other than stroke that can affect this. One is PML. Okay, so remember two things here, PML in association with AIDS and also with the MS medication natalizumab, which can cause PML. And so these patients present with visual loss. Okay, the other thing that can cause damage back here is Press syndrome. So very severe hypertension, and so these patients usually come in with seizures, and they can be blind with severe edema here in the posterior distribution. Okay, the macular fibers, or the macula in the occipital lobe is right at the tip of your occipital lobe. And so if you fall and hit the back of your head, and you have swelling at the back of your head, you can actually affect macular vision in both eyes. Okay, so sometimes we'll see this after a head trauma and patients come in with severe loss of visual acuity and they've lost their central vision. Okay, so remember, primary visual cortex is occipital lobe, but you don't read there. You don't do a lot of things as it relates to vision with your occipital lobe. So you identify things by sending that information to the temporal lobes, both sides. This is the what. Okay, what is it? What is that face? And also color recognition. Okay, the where of vision, being able to take in the whole room, to maybe track objects. The where of vision goes up to both parietal lobes. Okay, so remember, if we have bilateral occipital temporal lesions, these are patients that can't identify things. That's a visual agnosia. And a subtype of that is prosopagnosia. Can't identify a face and can't identify color. So because these are lower down, occipital temporal lesions, then the visual field deficit tends to be in the superior quadrants in both eyes. Okay, now if you have bilateral occipital parietal lesions, like a patient with Press syndrome, maybe a patient with PML, now you affect the where of vision. And so remember, simultagnosia is that ability just to take in everything at once when you look at it. So that's why looking at a picture of a face made of fruit or vegetables, all they can see is one onion or something. They can't take in the whole picture. That's simultagnosia. Optic ataxia is just it looks like ataxia, okay, but it is just a visual problem with finding where things are in space. If you ask these patients to touch their shoulder or their nose, there's no ataxia doing that because that doesn't involve vision. Okay, so this is known as Balint's syndrome. Okay, say a few words on the thalamus here, mainly from first year. So here's a normal MRI. There's the internal capsule. Lateral to the internal capsule is the globus pallidus and putamen. Medial is the caudate and thalamus. Okay, so we learned about lots of thalamic nuclei, and I'm just going to tell you these would be the 4 highest yields, so better know these. So lateral geniculate, we've talked about redundantly, is important for vision. Medial geniculate, of course, is for auditory information, and VPL and VPM are all sensation. So VPL is for your arm and leg. So remember, pain, temperature, vibration, proprioception, it's all headed to VPL for the arm and leg. And all of that facial sensory information we just talked about is headed up to VPM. Okay, so that would be the highest yield as a little sub-tier of that. VA is important for basal ganglia circuits. VL is for cerebellar circuits. And when we talk about the Papes circuit, it's the anterior nucleus of the thalamus that is involved there, coming from the mammillary bodies. All right, so I think probably the only clinical syndrome you should know about with the thalamus is if you have a stroke in the thalamus. Okay, and so that's going to affect VPL and VPM, of course, and so the patient's going to have loss of sensation on the opposite side of the body. Remember, this is one of our lacunar stroke syndromes, so it's a pure sensory stroke. And over time, these patients can develop pain, a chronic pain syndrome on one side of the body. Okay. All right, here's the subthalamic nucleus right above the substantia nigra. So, of course, a lesion there, we will get hemibolismus. Other parts of the diencephalon, so here's the thalamus, here's the hypothalamus, here's the pineal gland. So we've talked about pineal tumors and the effect that that can have on the dorsum of the midbrain there. All right, so here's the thalamus, and so I think the internal capsule would certainly be something important to know. So posterior limb, we've mainly talked about the posterior limb and the genu, because the posterior limb has the corticospinal tract and the corticobulbar tract. And what's important about that is they're in the same vascular distribution. So the lenticulostriate artery supplies corticospinal tract and corticobulbar tract. So this is our pure motor stroke. Okay, so remember lacunar stroke syndromes, you're just allowed one deficit, and in this case, it's just contralateral weakness of the opposite face, arm, and leg. Okay, now it would be nice here maybe just to draw in VPL and VPM, just put them there in the thalamus, because all that sensation for the opposite arm, leg, and face, it is getting up to the brain here through the superior thalamic radiations. This arrow is not meant to indicate it's going down. It's actually going up to the brain, okay? And so your pure sensory stroke usually involves a stroke here in the thalamus, but sometimes even it's of the sensory fibers here in the posterior limb of the internal capsule. Okay, and it's a totally different vascular territory. This is a thalamo-geniculate artery. This is posterior circulation. Okay, the lenticulostriate here to the cortical spinal and cortical bulbar tract, that's anterior circulation. It's coming off of the middle cerebral artery. Okay, so our two most common lacunar stroke syndromes are pure sensory stroke and pure motor stroke. Okay, what's in the anterior limb? Well, that cortical pontocerebellar tract that we just talked about, going to the cerebellum, that's in the anterior limb. This is Pape's circuit here that is in the anterior limb. And the frontal eye fields, the pathway that allows your brain to move your eyes, that goes through the anterior limb. Probably, I don't know how high yield that is, but the posterior limb and genu would be really important. By the way, if you had to say a lesion just of the cortical bulbar tract, what would the most likely clinical deficit be, do you think? Yeah, contralateral lower facial weakness. Okay, and here's a picture of that. Good timing. So here's the cortical bulbar tract. And so this supplies all of your cranial nerves, ipsilateral and contralateral, with one exception. Okay, so here's the cortical bulbar tract. And so notice here it's supplying the contralateral upper and lower part of the facial nucleus for the upper and lower face. But in this case, it only supplies the ipsilateral upper face. Okay, so that's why here we can, with a cortical bulbar tract lesion, like in the genu, you can get just the lower face can be affected. So here's an example of just a tiny little lacunar stroke there that you might see with a pure motor stroke. All right, here's our list of pseudobulbar palsy. I think we're going to stop at 9, regardless of where we're at here, but let's see how much we can get done between now and then. Pseudobulbar palsy, here's the list of the things that we've talked about. So far in this lecture, we mentioned ALS, upper and lower motor neuron, but it's all cortical bulbar tract. Okay, so cortical bulbar tract here. So this should be pretty easy. If you have a patient with pseudobulbar palsy, if they've got upper and lower motor neuron weakness, maybe fasciculations is part of that, it's ALS. If we have a young individual, a 25-year-old woman who sounds like she has multiple sclerosis because she has a history of optic neuritis and maybe double vision, well, if you demyelinate enough of the cortical bulbar tract, you'll get pseudobulbar palsy. PSP, remember that condition? Sorry, I'm not doing this, but anyway. PSP is, it looks like Parkinson's, but remember these patients can't look up and down, and oftentimes those patients will have pseudobulbar palsy. Multisystem atrophy, again, looks like Parkinson's, but they have severe orthostatic hypotension. Those patients will also frequently have pseudobulbar palsy. And then just if you have enough small strokes and you destroy more and more and more of the cortical bulbar tract, you'll have pseudobulbar palsy. But those are going to be older individuals with hypertension, diabetes, and hemiplegia. So hopefully you can distinguish here these 5 different causes of pseudobulbar palsy. Okay, let's talk a little bit about language. So we're still in the subcortical area, and remember the arcuate fasciculus is the pathway that connects Wernicke's with Broca's. And so if we have a lesion of the arcuate fasciculus, and you have a disconnect there, the patient can understand, and they can talk pretty well, but they do really poorly taking in a command to repeat something and then moving it forward to Broca's area. So they have a severe problem with repetition. All right, here's the corpus callosum, massively supplying both hemispheres. And so some disconnect syndromes we can have. One here is with a left PCA stroke. So now remember, the patient here is going to have a right homonymous hemianopsia. Okay, but if you ask this patient to look at something, they can see letters, but of course you don't read here. Okay, you read over here in Wernicke's area. And so these patients can see the letters, but they have no way of getting them over to Wernicke's area. So they have alexia, but it's without agraphia. So they can understand an auditory command to write things down. That goes right into, Heschel's gyrus, Wernicke's area, and they can write sentences, but then they can't read what they just wrote because they can't get the information over. Okay, so here is just a diagram that we went over kind of explaining alexia without agraphia. Okay, now this one, you can relax on this one because this was when we were still using the National Board subject exam for this course, and I couldn't believe they had this question in. So just relax and I'll explain it anyway. And I actually put this in a footnote because I was at the neurology conferences, they have like a quiz shows to see who's the smartest neurologist and all of that. And this was one of the questions, and almost no one knew it, but it was on the second year board exam. Anyway, so if you have a lesion here of the corpus callosum, more of the anterior corpus callosum, the question was, what clinical deficit will the patient have? And this is not intuitive at all. But let's just say, all right, so here's left hemisphere. You ask a patient, please flip a coin with your right hand. Okay, so they understand that, right? Goes into Wernicke's area. And so that has no problem moving forward then to the motor cortex in your left hemisphere. And then there's the corticospinal tract, and you can flip a coin with your right hand, no problem. Okay, but now if you ask a patient with a lesion right here, please flip a coin with your left hand. Okay, they understand, but to move your left hand, you need to activate the motor cortex over here, right? And so this pathway actually goes forward, and it crosses the corpus callosum. Okay, so they're not weak, right? This is not motor cortex, but they just can't get the information over here to the right hemisphere motor cortex. So when you ask the patient to flip a coin with their left hand, it's an apraxia, right? Which means it's not weak, it's not sensory loss. They've lost the motor program. They don't know what to do with their hand. So anyway, that is an example of a focal apraxia, and we probably shouldn't have wasted 2 minutes on that, but anyway. Okay, so remember as we do a close-up look here, here's the thalamus, here's the hypothalamus, and the anterior commissure is right here. Anterior commissure connects the temporal lobes. Okay, so hippocampus. So there's probably some importance here in terms of memory function for the anterior commissure. So the boundaries of the hypothalamus we went over last year. Here's the optic chiasm. Pituitary gland would be right below this. And here are the mammillary bodies. It's part of the hypothalamus, here forming the floor of the hypothalamus. Okay, let's just say a little bit about multiple sclerosis. Again, contrast with Guillain-Barré. So your typical multiple sclerosis is relapsing remitting. The patient has optic neuritis, they recover. They have an INO, and they recover. But the more attacks you have some deficits that don't recover completely. You have some permanent problems. And remember, this can then merge into what we call secondary progressive MS, where the patient just kind of accumulates lesions and gets worse over time. Okay, so here would be another one of our top 5 questions throughout medical school for neuroscience is a lesion of the MLF. That's another one like Brown-Séquard and lateral medullary syndrome and Horner's syndrome that you have to know. Okay? So we probably don't need to say much about this, but remember if you have demyelination here, which is usually due to MS, that the problem is with the ipsilateral medial rectus. Okay? So now if the patient who's looking at the screen is trying to look to the right, the left eye is not cooperating. It gets stuck in the midline. Okay? And then remember in the normal eye, it tries to bring the images together. So you get some nystagmus in the normal eye. So if I have a left MLF lesion and I look to the right, no problem. When I look to the left, this eye gets stuck, and then we get some nystagmus here in the normal eye. Okay, and what would be nice if it were drawn here is that convergence, so doing this is a different pathway. Okay, and so these patients can look to the nose if you ask them to follow your finger to their nose. Okay, so this is an internuclear ophthalmoplegia. Okay, so patient looking here to the right and the left eye is not cooperating. So we can see this with a stroke, small stroke here, but in a young person it's certainly MS. All right, so I'm not going to go over all of the transverse myelitis and the different things that can happen in MS, but of course the money in making the diagnosis is an MRI scan of the brain. So we see lots of periventricular areas of demyelination, little spots usually in the spinal cord, so anything myelinated by oligodendrocytes, okay, little areas of demyelination there in the spinal cord. And if you are just not sure what's the diagnosis here, you can do a lumbar puncture, and remember you look for oligoclonal bands, okay, which are seen in about 85% of patients with MS. So it's a good test to either help you rule out more or more suggest the diagnosis of MS. So remember, if you're asked, you've got a patient in the hospital who's blind in one eye from optic neuritis, or they can't move their legs from transverse myelitis, your treatment is steroids, right? Because like methylprednisolone, all of the preventive medications, they help to prevent relapses, but they don't help the acute episode. All right, so there are a lot of MS medications. So the two older ones are interferons and glutarin or acetate. Okay, these are still the ones that I've seen asked usually in the 3rd and 4th year board exams. But remember, dimethyl fumarate is an oral medication, very well tolerated. This is kind of rising to the top here of most commonly prescribed medications for MS. And I've really only highlighted a couple of things here, which natalizumab I think would be a really important one for you to remember. It's in studies our most effective medication for preventing MS relapses. The reason we don't just put everyone on it is it has this potentially, life-threatening condition, PML. Okay, so remember we have to measure a JC antibody before you put a patient on natalizumab, and you need to keep monitoring that with ongoing treatment. Okay, I put here another thing. The mechanism for a lot of these is so poorly understood, but this one is a designer drug, monoclonal antibody, and so this one would be worthwhile knowing. It attaches to the VLA4 receptors on T cells, and it basically makes them sticky. They can't get in through the blood-brain barrier to cause demyelination. Okay, I won't ask you about these two. Okay, we'll talk about that more in the 3rd year clerkship, but know about natalizumab for sure. Okay, a lot of overlap between MS and neuromyelitis optica, but some important differences. Okay, it's optic nerve and spinal cord, and not just exactly like MS, but much more severe attacks. So someone who is just blind in one eye with their first episode, that would be unusual for MS. Or the spinal cord lesions are not just little spots of demyelination, but these very long, extensive demyelinating lesions in the spinal cord. So quite different in that sense. And when you do an MRI scan thinking your patient has MS, what's going on? It's pretty normal. And you do a lumbar puncture, they don't have oligoclonal bands. So you need to do the aquaporin 4 antibodies, or we now more often call them the NMO antibodies, neuromyelitis optica. So we haven't really gone into treatment of this, which is not something I'd expect you to know now, but we treat it entirely different than multiple sclerosis. Okay, our last thing here before we get up to the cortex is Parkinson's disease. So I won't go over all of the basal ganglia circuitry again, but remember the payoff for understanding this is that basically if we have a condition like Parkinson's, the reason the patient slows down and they move less is because you're having less, the net result is less glutamate, which is excitatory, going back to the motor cortex. Okay, so the cardinal features of Parkinson's are asymmetrical rest tremor. So it's always hemi-body, one side of the body, so you get a rest tremor that improves with action. Rigidity is not something a patient's going to complain of, that's an exam finding. So you feel the muscle tone and it's stiff and rigid. Remember, that's different than spasticity because it's not velocity dependent. Okay, the disability though of Parkinson's is in this category, the bradykinesia or the akinesia. This is movement slowing down. They can't get in and out of chairs very well. They don't have any facial expression. They're drooling because their swallowing frequency goes down. Handwriting becomes small. All of these things are in the akinesia category. And then remember that the postural instability and falling, that's a late feature. So if it sounds like Parkinson's and the first complaint was, well, I started falling, you should think about a Parkinson's mimic. Okay, so remember these are really common in association with Parkinson's, depression, and after many years, in some cases, dementia. Dyskinesias, I'm going to stop using the pointer there. Dyskinesias, so a patient with Parkinson's will never have dyskinesias unless you give them dopamine. Okay, so this is due to upregulation of dopamine receptors, right? The brain's not getting dopamine, so it has many more dopamine receptors, and so then when you give a patient dopamine, if you give them too much, they have all these extra movements. Okay, so just YouTube Michael J. Fox in interviews, and he's always moving around like this. Those are dyskinesias. They tend to be a lot of head and neck movements. And that should suggest you're over-treating the patient. Although most patients would rather move more than less, so some patients will say, I'd rather have some dyskinesias. Almost every patient with Parkinson's is constipated, so it's a significant problem. They have seborrheic dermatitis, usually in the frontal area. Dystonia, remember that's a sustained muscle contraction, like the hand will go into a posture, or the foot will curl in, the toes will curl down. That's a sign of not enough dopamine. Okay, we mentioned loss of smell. Okay, and any synucleinopathy, which is Parkinson's, and multisystem atrophy, and diffuse Lewy body, you'll get REM sleep behavior disorder. So they act out their dreams at nighttime. Now, if you have these features, again, think of an alternative diagnosis. So if your patient kind of looks like Parkinson's, but they have early dementia, well, that's probably diffuse Lewy body. If they have early autonomic failure and they're passing out, that's multisystem atrophy. Okay, if they have early balance difficulty and falling, well, that could be a lot of different things, but it's a red flag that it's not just your run-of-the-mill Parkinson's disease. If they have early hallucinations, then it's, again, diffuse Lewy body. If they have other neurologic findings, such as ataxia or eye movement problems, we talked about that. PSP, you lose your vertical eye movements. And a big red flag would be you're giving the patient dopamine and they're not getting better. So patients with Parkinson's do great. You put them on dopamine and they improve significantly. Okay, so of course, normal substantia nigra, drop out of the dopamine-producing neurons. We look for Lewy bodies. Okay, so here's just a little bit of neuropathology. There's a Lewy body. So there's just some things, like a neurofibrillary tangle and a Lewy body, and I'm very glad Dr. Deich does that part of the course. So here are your synucleinopathies. And so again, all of these, we kind of lump them together. They often overlap a little bit, but all of these patients are going to have that REM sleep behavior disorder. Your tauopathies are Alzheimer's, frontotemporal, and progressive supranuclear palsy. Okay, here are the medications that I would know for Parkinson's. Remember pharmacology, and actually I have a board review on pharmacology that is on Canvas that I did a year or two ago. So if you want more detail, you can listen to that. But here's just in a nutshell, the ones I would know for sure for Parkinson's. Carbidopa, levodopa. Remember the carbidopa does nothing for the Parkinson's disease. This is to prevent nausea, and we talked about how that works before. So if you put a patient on carbidopa, levodopa, and they're throwing up, you just need to give them more carbidopa. Okay? So most common side effects of levodopa, I should say, are nausea and hallucinations. Okay, often florid hallucinations as you get too high, and then dyskinesias. Okay, dopamine agonists, so the two for Parkinson's are ropinirole and pramipexole. These also cause nausea and hallucinations, still the top two most common side effects, but these are unique because they cause impulse control disorder, okay, which we mentioned quite a bit because it's really common. Okay, and so this can be any number of things, an internet addiction, a gaming addiction, gambling, something like that. We always talk with patients about that. Sleep attacks from dopamine agonists, these are kind of unique. This is not like most medications where, boy, I'm just feeling groggy and sleepy. These are patients that are wide awake and then they just poof, fall asleep. Okay, so if I have a patient on a dopamine agonist who does that, we stop it immediately. They certainly can't drive if they have that because it's not your typical drowsiness. They just fall immediately asleep. Okay, anticholinergic medications for Parkinson's. The two we use are trihexyphenidyl and benztropine. Why do we rarely use these? Well, first of all, they only help for tremor. They don't help for any of the akinesia, slow movement. And so most patients, the tremor is not that big of a deal. They would just like to stand up from a chair and move better. And so these have significant side effects, again, on these muscarinic receptors. Okay, so dry mouth, constipation, urinary retention, and centrally confusion. Remember, entacapone or entacapone is a COMT inhibitor, and this only helps if you give it with levodopa. Okay, so if you have a patient on carbidopa, levodopa, and it's only lasting 3 hours, and then it's wearing off, and they're crashing and burning, and they can't move, if you add entacapone to that, it makes the levodopa last a little bit longer, and so they can survive, in between doses. Okay, I didn't include the MAOB inhibitors because most neurologists now are not using these for Parkinson's. But you should know about surgical approaches, so deep brain stimulation. The probe either goes in the internal segment of the globus pallidus or the subthalamic nucleus, and there's a big debate in neurology about which one is more effective, but it's pretty equal, actually. Okay, so if you have a patient with Parkinson's who is hallucinating, or maybe they're having some psychiatric features related to dementia, remember, you can't give that patient a dopamine blocking medication or they're not going to be able to move. So quetiapine is what we're using in that situation. So quetiapine doesn't have much effect on dopamine, so it's a good choice in that situation. Okay, so again, medications to be avoided in someone with Parkinson's would be the neuroleptics. I just put haloperidol here as one example, but risperidol, we go through the whole list. Or your antiemetics, metoclopramide or prochlorperazine. Okay, so amazing how many patients get put on these for some GI problem and then they just stay on it for years and then they end up looking like they have Parkinson's disease. Okay, so these cause Parkinsonism. Just other things that can look like Parkinsonism, remember PSP, decreased vertical eye movements, MSA with orthostasis, and you realize this is a great oversimplification. There's a lot more to these conditions, but these are the things that should jump out at you as suggesting it's not Parkinson's disease. And then remember MPTP. Okay, so I think I've only seen one patient with this. He actually was trying to make morphine, and he has what looks like severe Parkinson's disease from using that many decades ago. Okay, so side effects of neuroleptics. So one is Parkinsonism, okay, but another very sad side effect is tardive dyskinesia. I showed you a video of the lady who had been taking, I think, metoclopramide, and the key thing with tardive dyskinesia is its lower face. So they have these continuous grimacing, lower facial twitching movements. Sometimes the tongue will stick into the cheek, or sometimes it will dart in and out. And so if you see someone with mainly just lower mouth movements, that is tardive. And so you want to get a medication history, what medications you're taking or if you've been on. And sad thing about this is it can often be a permanent kind of a problem. Okay, if we have a patient usually in the hospital and they're getting some dopamine blocking medication, maybe IV for nausea or something like this, they can have an acute dystonic reaction. And so remember, dystonia is just a sustained muscle contraction. And so there are lots of these. The back can stiffen up, or sometimes the eyes will just be stuck looking up to the ceiling. That can be terrifying for patients. They're just stuck with their eyes up like that. Or sometimes one side of the body will go into a dystonia and it contracts. Lockjaw. And so this is usually pretty straightforward because we just gave the patient this medication and then they have this very dramatic reaction to it. Okay, so if you're an intern and you see that, we'll give a patient IV Benadryl, and that actually works pretty quickly. Okay, so dopamine blockers, we already talked about Parkinsonism. They can also cause akathisia. So this is just a feeling I can't sit still. I have to continually move my legs and stretch. And talking with patients or getting up and walking around in the exam room, okay, that's akathisia. And then remember neuroleptic malignant syndrome, the two features these patients all have is fever and rigidity. And so you might think, boy, maybe the patient is septic, it's an infection. But if they're on dopamine blocking medications, you want to, throw this into the mix. And so, maybe you do your metabolic workup and you can't find an infectious cause. Well, then that would make it more likely that perhaps it's our neuroleptic dopamine blocking medications. These patients are usually confused and oftentimes have a lot of autonomic instability. Remember, serotonin syndrome overlaps a lot with neuroleptic malignant syndrome, but of course these patients are on SSRIs, or on a different group of medications. Serotonin syndrome tends to come on more abruptly, and it stops abruptly once you eliminate the offending medications. And then remember, serotonin syndrome, you get upper motor neuron findings. So these patients have brisk reflexes and clonus. You don't see that with neuroleptic malignant syndrome. I think I have in your handout, but I didn't put here on the slide that for neuroleptic malignant syndrome, you can give dantrolene. So remember, the effect there is on the calcium and the sarcoplasmic reticulum, so that the muscles relax, get rid of the muscle rigidity. Okay, and then you can give dopamine agonists, also in a case of neuroleptic malignant syndrome. Okay, hyperkinetic movement disorders, by far, essential tremor is much more common than Parkinson's disease, but now it's an action tremor. Okay, and so any movement like eating, trying to use a tool, and the hand starts shaking, usually these run in families, and oftentimes it's not just the hands, but it's the head and the voice. So they have a shaky voice, and the head is bobbing up and down a little bit. And just historically, as we mentioned, it's so helpful if patients drink alcohol, what happens when you have a beer? Because that almost always brings the tremor down for a period of time. So only 2 medications help for essential tremor, but they really help. So primidone and propranolol. So our triad for Huntington's disease, of course, we have the caudate is affected, but look, the whole brain is affected with atrophy in Huntington's disease. So patients have dementia. It usually starts out with a behavioral problem, and they have a movement disorder. Remember, chorea is dance-like movement, so twisting, writhing movements. Patients often try to incorporate the movements into their activity. So many patients, they see smoke, and they will kind of use that as something that looks more socially acceptable to be doing something. And so, we have that triad, the family history. So now this is our 3rd trinucleotide repeat. We've talked about myotonic dystrophy, Friedreich's ataxia, and now Huntington's disease. This would be the most common one you would need to know probably of the trinucleotide repeats by what is affected, CAG on chromosome 4. Okay, so remember, tetrabenazine is a dopamine depleter. And so it actually is quite effective for the chorea movements in Huntington's disease. But the big problem with tetrabenazine is 30% of patients get depressed. Okay, and so the suicide rate in Huntington's disease is pretty high. And so that's the biggest challenge in using tetrabenazine in patients with Huntington's. Okay, so here are the trinucleotide repeats. I think I have a typo in your handout here with myotonic dystrophy, CTG, but Friedreich's, Huntington's, Fragile X, which we haven't talked about, and almost all of the spinocerebellar ataxia syndromes are trinucleotide repeats, but I've decided not to go over those in this course. Okay, hemiballismus, you'll all get this question right. I get a stroke in the subthalamic nucleus, contralateral, ballistic movements. Notice all the glutamate going back to the cortex. Okay, so it's a hyperkinetic movement disorder. Tourette's syndrome, so they have very prominent tics. Remember, it starts in young individuals, and usually the key thing that helps to make this diagnosis for me is it's not just motor tics, but they have vocal tics. So they're continuously clearing their throat, making sniffing sounds. So it's the vocal tics that often are just quite classic for Tourette's syndrome. So OCD is very common. So I told you my example of the patient who every time he walks across the line in the street, he has to back up and bend down and touch it. That's his OCD. but it could be, checking the locks or whatever. 60% of patients have ADHD with Tourette's. Okay, remember Wilson's is a problem with copper deposition, and it tends to deposit in 3 places. If it deposits mainly in the basal ganglia, then you'll get a movement disorder. That often goes along with dysarthric speech. Dysarthria is almost universal in patients with Wilson's. If it's also the brain involvement, often will be a psychiatric presentation as well. So a mood disorder, anxiety. If it deposits in the liver, well, sometimes I've seen patients, they come from the liver specialist who is suspicious of Wilson's. And then, of course, deposits on the cornea, we get the Kaiser-Fleischer rings. So this is in young individuals. We don't worry about Wilson's if we have a movement disorder in someone, let's say, over the age of 45. But pretty much any young individual with a movement disorder, we should always check for Wilson's disease. The tremor is different. Parkinson's disease, it's a distal tremor. You have someone with essential tremor, it's a distal tremor. With Wilson's disease, if you have them do this, their arm shakes here. So it's a proximal tremor, quite different than most movement disorders. So how do we diagnose? We do a 24-hour urine copper, which is high, and the serum ceruloplasmin is low. Okay, so that's how we'd confirm it. Okay, so remember the idiopathic focal dystonia conditions. So blepharospasm is recurrent contraction of the orbicularis oculi, and patients have these recurring eye closure episodes that they just can't control. Cervical dystonia is where neck muscles go into a sustained contraction. I have so many great videos of these patients that we just haven't had time to show you, but so their head will twist into abnormal positions. Writer's cramp is one example of a task-specific dystonia. So the hand is basically normal with everything that the patient does, except when they try to write, and then the hand goes into a dystonic posture. Spasmodic dysphonia is a dystonia of the vocal cords. So they either come together, in which case the patient has a tight, squeaky voice, or they go apart, and then the patient has a very breathy voice. So all of these are very responsive to Botox injections. Okay, so even injecting the vocalis muscle is very effective for those patients. So you can inject the orbicularis oculi, and the eyes, it's almost miraculous. They can keep their eyes open. You inject the neck muscles, and their head isn't twisting around anymore. Okay, we're up. We have 8 minutes to do as much as we can in the cortex. Okay, so eye movements. Of course, you remember that frontal eye fields, the left frontal eye field is trying to move your eyes to the right. Right frontal eye fields are trying to do the opposite. And it does that by traveling down to the opposite PPRF6 nerve complex. Now your lateral rectus moves. Here, if the patient's looking at the screen, the left brain makes the right eye move to the right, and the left eye via the MLF, third nerve, also moves to the right. So the payoff for knowing that is that you can figure all kinds of things out. If we have a left MCA stroke, and now you knock out the frontal eye fields, well, first of all, you know with the left MCA stroke, and you're going to affect the corticospinal tract, the patient's going to have a contralateral hemiplegia. Okay, but if you destroy the frontal eye fields, now the eyes can't look to the right. Okay, so the eyes get driven to the left. All right, so the right side of the body is weak. The eyes are looking to the left. So the easiest way to remember it is that in an MCA stroke, the eyes look away from the hemiplegia. In contrast to a stroke in the Pons, okay, which now the eyes look at the hemiplegia. Okay, and I'll let you just look at that diagram a little bit on your own to convince yourself of that. But that's the big difference between an MCA stroke and a lesion in the Pons. If we have a seizure in the left hemisphere, now we're activating these pathways. So the left brain normally wants to drive the eyes to the right. Well, now that pathway gets stimulated. So the eyes look to the right. The left corticospinal tract is activated. So now the right side of the body is shaking. So in a seizure that starts here in the left hemisphere, especially the frontal lobe, now the eyes will look at the shaking arm and limb. Okay, and of course, we just talked about an MLF lesion. Okay, I just wanted to remind you here the function of the superior oblique. So we've got the eye out here and a third nerve palsy. The superior oblique will cause that intorsion movement. That tells us the fourth nerve is intact. Okay, and remember, patients with fourth nerve palsies, often they don't know when it started, but they're always walking around with their head tilted. Okay, and that helps to bring the images together. Sixth nerve palsy, of course, when you just look at a patient here, you lose that tone from the lateral rectus, and so the eye tends to get pulled towards the nose a little bit. And of course, if we were asked this patient to look to the left, if he's got a left sixth nerve palsy, this eye will move to the nose, and this eye will just kind of stay there. Okay, skip over that. All right, so I think, the just trickiest thing is just to remember the superior oblique, I think. The rest are, I think, pretty straightforward. Worthwhile to know the homunculus, just out here on the precentral and postcentral gyrus. Remember down here that the face has a very large representation, which makes sense. It's right next to Broca's area. Okay, so big facial representation for motor, sensory. The arm is up here. And then remember the leg fibers and the paracentral lobule are midline. Okay, so an MCA stroke then. We're going to have a contralateral hemiplegia, hemisensory loss, the gaze preference. Okay, that's the eyes looking away from the hemiplegia. Okay, and then if it's dominant hemisphere, usually left hemisphere, we'll have an aphasia. And if the stroke is more anterior, it'll look more like a Broca's. If it's more posterior, it'll look more like a Wernicke's. And if we have an isolated stroke, even behind Wernicke's area, then we'll get the Gersman syndrome. Okay, if we have a right MCA stroke, okay, this is when we get the denial of illness, anosognosia. I'm fine, doctor. They can't move the left side of their body. Or the asomatosognosia, which remember is denial of the involved body parts. You have them hold up their paralyzed arm and they say that it's not their hand. Hemispatial neglect and extinction, so they deny the opposite side of space. When you touch them in both arms at the same side, they will only recognize everything that's on the right side. They'll deny everything that's off to the left. So here are the different aphasia syndromes. And let's go with the ones that are easy first here. So global aphasia, of course, is a big left MCA stroke. Now the patient, Broca's is knocked out, so they're not fluent. Wernicke's is knocked out, so they can't understand. And of course, they can't repeat. So that's a big left MCA stroke. If our stroke is more anterior, and it's a Broca's aphasia, so these are non-fluent, right? They just get a few words out. But if Wernicke's area is intact, they can understand. Okay, but you lose everything coming from Wernicke's area, so they can't repeat sentences very well. And Broca's area is on the inferior frontal gyrus. Okay, if we have a Wernicke's lesion, if it's just isolated, Broca's area is okay, so the patient's babbling, right? It's fluent, but they're not making any sense. So they can't comprehend what you're saying, and they can't repeat because they didn't understand what you just said when you asked them to repeat a sentence. So here the lesion, Wernicke's area, is mainly on the posterior superior temporal gyrus. And then remember, a conduction aphasia, we just have an isolated problem with repetition. Now, the transcortical motor and sensory, these are our usually watershed strokes, where you have a stroke surrounding Wernicke's and Broca's area, but not directly involving Wernicke's and Broca's area. So this looks a lot, the transcortical motor looks a lot like a Broca's aphasia, and supposedly these patients do better repeating because, they've got an intact Wernicke's, arcuate fasciculus, Broca's connection. So that would be the main difference there. In a transcortical sensory, again, it's the areas surrounding Wernicke's area, and so the arcuate fasciculus is fine. So these patients also repeat. And again, the question you should ask is, well, how can they repeat if they don't understand? And the answer is they just echo things back. They don't really understand. So you're talking with them, and they will just echo words back that you are saying. And so anyway, I think knowing the global Broca's, Wernicke's, and conduction would be probably the key ones to remember. If you are just shown a picture like this, all the numbers on one side, that's a right MCA stroke, right? The patient is denying the existence of this entire space over here. Okay, again, another picture of the homunculus. So MCA stroke, frontal eye fields, Broca's, Wernicke's, and there are the optic radiations. You need to be able to recognize the MCA territory. Remember, Gerstmann's is way back here, angular gyrus area, so it's behind Wernicke's, left hemisphere. Okay, we already talked about alexia without agraphia. All right, remember our ACA stroke here supplies the paracentral lobule, and so patients have contralateral leg weakness, sensory loss, and there's the bladder. They have urinary incontinence. So here's an ACA stroke. This patient has a bilateral ACA stroke, so could present with bilateral leg weakness. Okay, so in general, remember stroke risk factors often come from the heart, especially atrial fibrillation. Remember the story of amaurosis fugax. It's painless visual loss in one eye, like a mist or a shade being pulled down, and then it gradually clears. So if you get that story, you know that this almost certainly came from the carotid artery, so you have to do a carotid ultrasound. All right, the hemorrhages. Remember, look a lot like the ischemic strokes, but we've got some mass effect here. So now with a hemorrhage, there's usually a headache, and usually there's some confusion from the mass effect. And so the most common one is the putamenal hemorrhage. So here it is right next to the posterior limb. So these patients usually have a hemiplegia. And they can look like an MCA stroke, but again, you've got increased intracranial pressure. Here's the more midline thalamic stroke. Okay, and so this also may have a hemiplegia, certainly a hemisensory loss. Okay, but remember the thalamus right here sits right on the midbrain. So here's another example of the midbrain affected by something with mass effect. So this patient will probably have a hard time looking up and down because that's a function of the midbrain. Pontine hemorrhage, usually patients in a coma, pinpoint pupils, and then remember the breathing pattern is apneustic respirations, taking a deep breath and hold it. And again, these are the ones that, the hypertensive hemorrhages that you can surgically do something about. So ipsilateral ataxia, usually they're going to have a headache back here, neck stiffness because of the mass effect. Okay, so our watershed strokes. So there are several areas of the brain that are susceptible to hypoxia, especially in between the major vascular territories. So between MCA and ACA, for example. And remember, there is a watershed distribution within the MCA territory. Okay, so a stroke here, this can give us that person in a barrel syndrome because the proximal muscles for the arm and leg tend to be kind of in this distribution. So they can be pretty strong distally but have proximal weakness. Okay, let's not go through venous circulation here. Maybe that's a good place to stop. So let's stop there. And good. Thank you. Good luck.